Every minute, somewhere in this country, another family sits in a clinic room and hears words that change the rest of their life. Memory loss, cognitive decline, possible dementia. And when that happens, most people look at age first. They blame birthdays, they blame stress, they blame bad sleep. But sometimes the real trigger is not aging at all. Sometimes it is the medication sitting in a cabinet, lined up next to vitamins and toothpaste, taken faithfully because it was prescribed, recommended, or sold over the counter like it was harmless. I'm Sophia, and today I want to walk you through 9 categories of medications that can interfere with memory, attention, clarity, and day-to-day thinking, especially in older adults. I'm counting them down from the ones that people overlook to the one I believe causes the most hidden damage of all. Watch closely for number 3, because it hides in plain sight, it is still widely prescribed, and many people taking it have never once been told it can weigh on the brain. Before we start, I need to say one thing clearly. This is not a list of medications you should stop on your own. Some of these drugs help people in real and important ways. The goal here is not panic. The goal is awareness, because you cannot protect a brain you are not taught to question. Let's begin. Number 9 is the little pill people trust because they can buy it without asking anyone. Number 9 is diphenhydramine, better known by the brand name Benadryl. It is used for allergies, it is used for sleep, it shows up in many nighttime cold products, PM pain relievers, and cough formulas. And because it sits on an open shelf, many people assume it is gentle. But for an older brain, that assumption can be very costly. Diphenhydramine has strong anticholinergic effects. That means it blocks acetylcholine, one of the brain chemicals involved in attention and the formation of new memories. In younger adults, the effect may show up as grogginess. In older adults, the same chemical block can hit harder, last longer, and look like real cognitive decline. A medication review becomes even more important because many people are exposed more than once without realizing it, taking the same ingredient under different brand names. This is why first-generation antihistamines like diphenhydramine appear on the Beers criteria, the American Geriatric Society list of medications that are often inappropriate for older adults. If you use it for allergies, ask whether a newer non-sedating option would be safer. If you use it for sleep, do not assume a pill sold without a prescription is the safest road to rest. Number 8 is a group of medicines people take for the bathroom, while the brain quietly pays the price. Number 8 is bladder antimuscarinic medication, especially oxybutynin. These drugs are prescribed for urgency, frequency, and overactive bladder. The relief can feel life-changing. Fewer accidents, less fear of leaving the house, better sleep at night. But the same mechanism that calms the bladder can also burden the brain. Oxybutynin has strong anticholinergic properties and is specifically called out in the Beers criteria. It is one of the urinary medicines with the clearest evidence for adverse cognitive effects in older adults. People often describe the change slowly. They lose words mid-sentence. They walk into rooms and forget why. They miss appointments they normally never miss. And because the medication solved one obvious problem, nobody thinks to connect it to a second, quieter one. If this sounds familiar, it does not mean everyone must stop treatment. It means the conversation needs to widen. Ask whether the medicine is still necessary, whether the dose can be reduced, or whether a non-anticholinergic alternative such as mirabegron could fit your situation better. The key is not choosing your bladder over your brain. The key is refusing to sacrifice one without knowing it. Number 7 is taken for pain, sleep, and mood, and that versatility is exactly what makes it so dangerous to miss. Number 7 is amitriptyline and related older tricyclic antidepressants. These medicines have been around for decades, and many clinicians still use them for nerve pain, migraine prevention, insomnia, and depression. The problem is that tricyclics are not just sedating. Many of them are strongly anticholinergic, which means they affect the same memory pathway we just talked about. Long-term cumulative anticholinergic exposure has been linked in large observational research to higher rates of dementia, and tricyclic antidepressants are one of the main categories driving that burden. The risk is especially easy to miss when the dose is small, because a low nighttime dose can feel harmless. But a small dose repeated for months and years is still exposure. That is how people wake up one day wondering when their sharpness started thinning out. If you take amitriptyline, it is worth asking what problem it is actually treating. If it is being used for sleep, there may be gentler strategies. If it is being used for pain, there may be other options with less cognitive burden. If it is being used for depression, there are newer antidepressants that are often easier on the aging brain. Number 6 is not sold as a memory drug, but it can absolutely shape the way the mind feels from morning to night. Number 6 is the broad family of benzodiazepines. This includes medicines such as lorazepam, diazepam, alprazolam, temazepam, and clonazepam. People are given them for panic, anxiety, insomnia, muscle tension, and sometimes just to get through an overwhelming season. At first, the effect can feel like rescue. The body relaxes, thoughts slow down, sleep returns. The problem begins when short-term relief becomes long-term dependence. Older adults are more sensitive to benzodiazepines, and clinical guidance is blunt about the risks. They increase the chance of cognitive impairment, delirium, falls, fractures, daytime sedation, and car accidents. Many people do not describe it as feeling drugged. They describe it as feeling less like themselves. Slower recall, blunted focus, a strange emotional flattening, a sense that the lights are on but not all the way bright. The hardest part is that stopping suddenly can be dangerous. If you have been taking a benzodiazepine regularly, do not quit abruptly. Withdrawal can be severe, and in some cases life-threatening. The safer path is a supervised taper with your clinician, combined with a plan for what will replace the medication, whether that is therapy, sleep treatment, or a different non-sedating medicine. Number 5 is the category many families never realize they consented to at all. Number 5 is antipsychotic medication used in older adults, especially when it is started for agitation, restlessness, sleep, or behavior changes in dementia. Drugs like quetiapine, risperidone, and olanzapine were developed for serious psychiatric illness, but in real life they are also used off-label in frail older adults because they can make difficult behavior easier to manage. That convenience can come with a heavy price. Antipsychotic use in older adults with dementia is associated with increased risks, including stroke and death, which is why these medications carry a boxed warning. They can also cause heavy sedation, emotional blunting, slowed movement, and a visible dimming of engagement that families often mistake for the natural progression of disease. Sometimes these medicines are necessary for severe distress or dangerous symptoms, but when they are used, the question should never be, can this person be made quieter? The question should be, what problem are we truly treating, and have we exhausted safer options first? A medication that calms the room may also be stealing presence from the person. Number 4 is easy to underestimate because it is often described as modern, common, and routine. Number 4 is paroxetine. Among selective serotonin reuptake inhibitors, paroxetine stands apart because it also has meaningful anticholinergic activity. That matters, especially in older adults, because a medicine chosen for mood or anxiety may quietly add to the same cognitive burden created by nighttime sleep aids, bladder drugs, and older pain medications. Paroxetine is listed on the Beers criteria as a strong anticholinergic antidepressant. That does not mean it is never appropriate. It does mean that when an older adult is taking it and reporting brain fog, memory trouble, or slowed thinking, the medication itself deserves a hard second look. In many cases, clinicians can consider other antidepressants with a lighter anticholinergic load. This is one of the most important patterns in the entire video. The danger is not always a single dramatic drug. Often, it is one more anticholinergic added to a stack that was already too heavy. Number 3 is the product hiding in plain sight in homes across the country. Number 3 is the entire world of nighttime combination products, PM pain relievers, cold and flu sleep formulas, allergy and sleep blends. A huge number of them rely on diphenhydramine or another sedating anticholinergic ingredient to create the feeling of rest. That means people who say, "I do not take Benadryl," may still be taking Benadryl under a different label every night. This is why medication reviews have to include every over-the-counter bottle, not just prescriptions. A person may be taking oxybutynin from a urologist, peroxybutynin from a urologist, paroxetine from a primary care doctor, amitriptyline from a pain specialist, and a nightly PM product from the drugstore. No one step looks catastrophic. Together, they create a cognitive tax that the brain pays daily. If you are over 60, read the active ingredients on everything you take, not the front of the box, the ingredients. Because a branded promise of sleep, allergy relief, or cold comfort can hide the very compound that is clouding your mornings. Number 2 is a category people use for acid relief, but the story here requires more nuance than fear. Number 2 is proton pump inhibitors, medicines such as omeprazole and esomeprazole. You have probably heard dramatic claims online linking them to dementia. The truth is more complicated. Some observational studies have found associations. Other high-quality data have not shown that PPIs cause dementia or cognitive decline. So I am not putting them here because the science proves they damage memory in the same way strong anticholinergics do. I am putting them here because they are often continued for years without review. That matters because every long-term medication deserves a reason. If you have severe reflux, Barrett's esophagus, ulcers, or another clear indication, your clinician may decide that a PPI remains exactly the right choice at the lowest effective dose. But if you started one years ago for a brief stretch of heartburn and never revisited it, the bigger lesson is this: medications should not become permanent just because they became familiar. And now number 1, the most destructive pattern of all, not because it is the loudest, but because it is the easiest to miss. Number 1 is cumulative anticholinergic burden, also called anticholinergic polypharmacy. This is what happens when several medications with anticholinergic effects pile up together and no one adds the total. One for sleep, one for bladder symptoms, one for mood, one hidden inside a cold product. One older medicine never discontinued after a problem changed years ago. This is the pattern older adults and families miss most often. Not one villain, but a stack. Not one dramatic side effect, but gradual dimming. Names become harder to find. Focus becomes fragile. Processing slows. The person begins to doubt themselves. Then the family starts whispering about aging, and the true cause may still be sitting in a weekly pill organizer. The Beers criteria specifically warns that cumulative exposure to anticholinergic drugs is associated with increased risk of falls, delirium, and dementia. Large observational studies have also found a dose-response relationship, meaning the higher the cumulative use of strong anticholinergics over time, the higher the observed dementia risk. That does not mean every case is reversible, and it does not prove every person will decline the same way. But it does mean this burden deserves real respect. Here is the hopeful part. Medication-induced cognitive problems can sometimes improve when the burden is identified and reduced carefully. Not overnight, not magically, but enough to change a life. That is why the most valuable appointment on this topic is not a rushed refill visit. It is a full medication review. Now, let me slow this down and show you what this looks like in real life. Because this issue almost never announces itself dramatically. It usually arrives by inches. A person who has always managed the family calendar starts missing birthdays. A man who has driven the same route for 20 years suddenly hesitates at a turn that used to be automatic. A woman who used to carry 6 details in her head begins writing everything down, then loses. These changes rarely begin with one spectacular collapse. More often, they begin with a little more fog in the morning, a little less patience in conversation, and a little more effort to do things that once felt easy. That is why medication-related cognitive decline is so easily mislabeled. Families see slowness and assume aging. Doctors see several chronic conditions and focus on the illness being treated. Patients feel embarrassed, so they minimize what is happening. And because the changes can be gradual, nobody notices the timeline. The sleep aid started 6 months ago. The bladder medicine started a year ago. The anxiety pill dose was doubled after a hard season. By the time memory becomes a real worry, the connection feels invisible. Here is something else that matters. The brain does not care which doctor wrote the prescription. It experiences the combined effect. A cardiologist may not be tracking what the urgent care doctor recommended. The primary care clinician may not know what is in the over-the-counter PM product. The patient may not realize the pink allergy pill and the nighttime cold medicine contain the same sedating ingredient. That is how burden builds. So when you ask for a medication review, do not ask for a quick glance at your active prescription list. Ask for a true review. Bring the bottles, bring the sleep gummies, bring the herbal products, bring the allergy tablets from the grocery store. Bring the things you only take on weekends, the things you borrow from a spouse, and the sample packs still sitting in a drawer. The hidden problem is often sitting outside the official chart. And when that review happens, listen for language that sounds precise, not vague. You want to hear words like anticholinergic, sedating, deliriogenic, long-acting, falls risk, dose reduction, deprescribing, substitution, lowest effective dose. These are the terms that turn a passive refill routine into active brain protection. You can also ask for a simpler explanation if the medical language feels overwhelming. Try this. Which medicine here is most likely to affect memory? Which one is most likely to make me unsteady? Which one would you question first if I were your parent? Those questions get to the heart of it fast. There is another reason this topic matters so much after 60. Aging changes the way the body handles medication. Kidney function can decline, liver metabolism can slow, body composition shifts. The blood-brain barrier becomes more vulnerable. A dose that felt tolerable at 50 can feel very different at 75. The medicine did not suddenly become evil. The body changed, and the old dose may no longer fit the new physiology. That is also why "I have taken it forever" is not always reassuring. In some cases, long use is exactly the issue. Exposure accumulates. Sensitivity increases. New medications get layered on top of old ones. Then one day, the person is not reacting to one pill. They are reacting to the total history of all of them together. I also want to say something for caregivers, because caregivers often notice the pattern first. If you have been told this is just normal aging, but you can trace the change to when a medicine was added, trust that observation enough to raise it again. You do not need to accuse anyone. You do not need to arrive frightened. Just be specific. Say, her confusion seems worse since this started. Say, his balance changed after that dose increase. Say, mornings have been foggier since the nighttime medicine was added. Timelines are powerful clues. And if the answer you get is dismissive, ask for a pharmacist consultation. Pharmacists are often the hidden experts in medication burden, drug interactions, duplications, and safer alternatives. A thoughtful pharmacist can spot patterns that busy visits miss. Finally, do not let a frightening conversation push you toward the opposite mistake, which is stopping everything at once. More is not always better in medicine, but neither is chaos. The safest path is a deliberate plan, one change at a time, one taper when needed, one substitution when appropriate. Enough follow-up to see whether clarity improves, sleep worsens, anxiety returns, or bladder symptoms flare. That is how you protect both safety and dignity. If this list gives you one new habit, let it be this. Whenever a new medicine is suggested, ask one extra question before you agree. How could this affect my thinking, my balance, or my memory over time? That single question can prevent years of unnecessary fog. One more point before we close the countdown. Not every memory complaint is dementia, and not every medication side effect means permanent injury. Sometimes the earliest sign is not forgetting a loved one's name. It is mental fatigue. It is needing longer to follow a recipe. It is reading the same paragraph twice. It is losing confidence because the brain feels one step behind the day. Those quieter symptoms matter because they are often the stage when a medication review can do the most good. So if you have been telling yourself, I am probably just tired, I am probably just stressed, I am probably just getting older, pause and look at the timeline. What changed in the last 3 months? What changed in the last year? What was added? What dose increased? What began as occasional use and became nightly routine? Those answers can reveal patterns that memory tests alone do not. And if you are a clinician, a family member, or a caregiver watching this, remember that reassurance is only helpful when it is earned. Sometimes the kindest thing you can say is not, "This is normal." Sometimes the kindest thing you can say is, "Let's look at the medicines first." Because when the cause is medication, the most important breakthrough is not a headline diagnosis. It is recognition. Recognition creates options. Options create safer choices, and safer choices can preserve independence, conversation, confidence, and the small daily abilities that make a person feel like themselves. That is why this conversation matters before the fog gets explained away as fate. For families, bring every prescription, bring every over-the-counter product, bring every sleep aid, allergy pill, bladder medicine, pain tablet, and supplement. Ask 3 direct questions. Which of these affect acetylcholine? Which of these may cloud memory or increase falls? Which of these are no longer necessary or could be replaced with something safer? And remember this, never stop a medication abruptly unless a qualified clinician tells you to. That matters especially for benzodiazepines and some psychiatric medications. The goal is not rebellion. The goal is intelligent review. If you take nothing else from this countdown, take this. Aging can change memory, yes, but age should never be used as an excuse to stop asking better questions. If a person becomes foggy after a medicine is started, the timing matters. If confusion deepens after doses increase, the pattern matters. If multiple anticholinergic drugs are taken together, the total matters. Your brain deserves the same protection you give your heart. It deserves the same curiosity you give your lab results. And sometimes the most powerful way to protect it is not by adding a new supplement or chasing a miracle cure. Sometimes it is by looking with fresh eyes at the pills already in the house. So now I want to ask you something simple. How many medications are in your daily routine right now, including over-the-counter products? Have you had a real medication review in the last year? And after hearing this list, which item surprised you most? Tell me in the comments, and if this video helped connect a few dots for you, share it with someone who keeps a nighttime pill by the bed, a bladder medicine in the drawer, or a weekly pill box on the kitchen table. One conversation really can change the next year of someone's life. I'm Sophia. Stay sharp, stay curious, and I'll see you in the next one.